Hi, my name is Felice. I'm a pediatric neuroradiologist at Great Ormond Street Hospital for Children in London, UK, and I will be speaking about conductive hearing loss. I would like to thank Spin for the invite. It's great to keep knowledge for everybody like they are doing for little fees. So we are very thankful for that. So I want to share, first of all, that this presentation is based mainly on my clinical practice and on this beautiful paper. You know, guys, how important is to get your literature right. And Professor Robson from Boston Children is one of the best in pediatric head and neck. And she wrote this beautiful paper in 2023. So this year, very recent, download it, please. I will show you some images from this paper. Also, if you like pediatric neurologists, neurogeology. I put all my lecture on YouTube, free for all, are very simple lecture. So have a look if you want. Let's start with the basics. So basically, this is from Kelly paper. Abnormality resulting in conductive hearing loss can be located anywhere from the pinna, external auditory canal, and staped foot plate. So including the the middle ear, and are different from the sensory neural hearing loss that involves the nerve, the cochlear nerve, and the inner ear. Now, look at this anatomy. So there is the malleolar head here, the incus malleolar incutial joint with this small line of hypodensity that needs to be preserved, and then they appear here and a bit cranially as these two ossicles are two parallel lines. And this is very important. I will show you why when we evaluate the inflammation. We may need specific reformat to see the stapes, and most importantly, guys, remember, you need to see the oval window, and you can follow here the bone in the otic capsule that is interrupted here because this is the region of the oval window. And if you see bone all the way, you cannot identify this soft tissue window, you may be dealing with oval window atresia that you need to diagnose. And this is the appearances of the ossicular chain in coronal. This is not a lecture on the anatomy, but please remember, you need to know the anatomy very well if you want to pick up subtle pathology. Another important thing that you need to keep in mind, for conductive hearing loss, you need to use CT. If you have the cone beam CT or 3D flat panel that give you more resolution, spatial resolution than the multidisciplinary, multi-slice CT, please use a cone beam. The problem with pediatrics is that cone beam is very susceptible to movement artifact, and of course, in children without GA, it's very difficult to have perfect images. So, bottom line, if you have the cone beam for conductive hearing loss, use the cone beam, but only if you are sure that the child is compliant. Now, most important thing to remember in terms of development of the ear is that the middle and external ears, they develop together from the first and second branchial arch. And you can see the ossicles developing in blue from the first branchial arch, in green from the second branchial arch, while the foot plate develops together with the otic capsule. So the inner ear, which is in the otic capsule, and the foot plate develop separately. And although there are some overlap, it's very important that when you have an abnormality in the pinna, like in image A as opposed to B, you need to check carefully for middle ear abnormality. And you see here the abnormal ossicles, atresia of the external auditory canal, as opposed to a normal external auditory canal and normal ossicles within a well-aerated tympanic cavity. The foot plate of the stapes can be malformed in both middle ear or inner ear malformation. There are situations, syndromic causes of conductive or mixed hearing loss that are associated sometimes with inner ear development, but as a general rule, you can have inner ear malformation in isolation. But when you have an external ear or pinna malformation, you need to look very carefully for middle ear and ossicular abnormality because they develop together. We have very different causes of conductive hearing loss, mainly environmental and multifactorial, but also syndromic causes. Some of them have a genetic reason for them. So let's start with the normal anatomy on corona. What is very important is that you could see, of course, this is the inner ear, but you should be able to see the oval window as a notch here, and you follow the bone. Here you have two areas of soft tissue density. This is the seventh nerve, and this is the oval window. You can also see an area here of air density in connection with the basal turn of the cochlea. This is another coronal view, and this is the round window. Of course, if you have a problem in the development of the middle ear, you can have conductive or mixed hearing loss due to oval window atresia. Look at this is normal side on the left, normal patency of the oval window. Here, this is not the oval window. This is the seventh nerve, and instead of being up there, is down, so moved caudally in the expected location of the oval window. But the oval window is not visualized, and in fact, you can follow bony density all over around the inner ear hypodensity. So this is oval window atresia in corona, and look in the axial normal with stapes going there, and here you cannot see the oval window, and there is an overlap with the course of the seventh nerve canal in the expected location of the oval window notch that is absent. So this is the oval window atresia with malpositioned facial nerve. So look at the position of the facial nerve. The ENT surgeon need to know, and follow the bones, expecting a normal notch of hypodensity, which in this case is not present. So the pearl is, you know your anatomy, you will recognize subtle abnormalities. But also don't forget the round window. I showed you before. Let me come back one moment. This is the round window appearance on corona. This is the round window appearance on axial. And look, this is full of air. This needs to be well aerated. Sometimes it's stenotic. This is another cause of hearing loss, and you need to diagnose it properly. This is so difficult sometimes and so unknown that they dedicate this beautiful paper called The Forgotten Second Window, a picture review of round window pathology. So remember to look at the round window as well as the oval window. Now, we can have stapes abnormalities. These are from Kelly's paper. Again, beautiful images of the difference abnormality of the stapes. This is stapes, a monopod stapes. It's just malformed with only one single bone going into a dysplastic or not well developed oval window. But sometimes we have a superstructure of the stapes that is very dense in some syndromic causes like the George, for instance. This is another cause of the George with very dense stapes and abnormal ossicles. I will show other example. This is another syndromic causes of conducting hearing loss with, look how this plastic thickened and with bony thickening are the ossicles. This is supposed to be the normal malleolostapedial joint, but is completely dysmorphic. And I do suggest, guys, to have a normal controls for with the same scanner in order to compare normal and abnormal, especially in syndromic situation when you can miss some abnormalities that may be relevant for the surgeon to know before approaching this child. I told you about syndromic causes of hearing loss, mixed or conductive. Sometimes they change over time. Look at this case. We have an abnormal pinna, okay? So we do expect abnormal middle ear abnormality. So we do expect conductive hearing loss in these cases. This child has these plastic ossicles. You can see here they are fused, the malleolus and incus ankylus to the abnormal wall of the middle ear cavity, which is also small. And remember, when the middle ear cavity is small, is also prone to otomastoiditis and cholesteatoma. So this is an extra kind of cause of conductive hearing loss that can present on top of the malformative cause for it. But here we also have a small cochlea. If you're interested, there are a lot of papers on measurement. We did a review in the 2017 on measurement of the inner ear, but in coronal, the cochlea should be at least 4.3 millimeters. In this case, it's 3.3, definitely smaller. And there is also this unwound hypoplastic cochlea with this anterior offset of the apical part of the cochlea here and there. So this is, in this clinical context with renal problem and deafness, pathognomonic, so bronchioautorenal syndrome, which is autosomal dominant. You have hearing loss, auricular malformation. You need to look for bronchial cleft or anomalies and renal abnormalities. So cochlear hypoplasia and wound, but also abnormal ossicles plus other abnormalities, including this pin. So remember, this is another cause of very complex association related to syndromic hearing loss, and you need to look for them. Again, in the same neuroimage clinical North America issue where there is the paper from Kelly Robson, we wrote with Kelly Robson a paper on syndromic causes of hearing loss that summarize all these complex association that can be helpful in your clinical practice. Look at this other case. I will keep it practical and case-based. This is a female 7-year-old with genetic diagnosis of 3MC syndrome. And they had this possible right ear cholesteatoma on examination. 3MC syndrome, we just Google it because, of course, gosh, we have so many complex cases, we cannot expect to know them all, but 3MC syndrome is due to this gene MASP and is associated again with a complex syndromic association between kidney, heart, and eye disease, including hearing loss and craniosynostosis. We didn't know before this case report that we published what was the cause for hearing loss, but you can see how this is a small tympanic cavity with some soft tissue opacification. Now, they thought there was a cholesteatoma, but are we really sure? First of all, look at the scutum here. The scutum should be sharp and triangular. Here is truncated. And also the profile of the bones is a bit, it looks a bit eroded. So this is probably a very small cholesteatoma. However, if you look at here, this is not a pure conductive hearing loss. The clinical history mentioned mixed hearing loss. So we need to keep looking because pediatrics patients are very complex, especially in syndromic context. And look at this. There is no semicircular canal. The vestibule continues in this like bulbous lateral semicircular canal, which we call persistent anlage of the lateral semicircular canal, meaning that we don't have bony island formed, and we just have the lateral semicircular canal completely fused. So when you read in the report, persistent anlage of the semicircular canal is this appearance here where the semicircular canal failed to form and to detach with a properly formed bony island from the vestibule. And also the cochlea, you can see there is some abnormality in the lateral aspect of the cochlea resembling incomplete partition type 2. You will have another lecture on sensorineural hearing loss and malformation, but so there is a cochlear malformation, vestibular malformation, and a small cholesteatoma, probably as a consequence of the congenitally small middle ear. On top of that, craniosynostosis, and we only have the page response CT, but look at the prominent veins that suggest an abnormal venous drainage from the skull base. Again, your ENT surgeon needs to know this. And we did a diffusion. Remember to use non-epiplanar diffusion for cholesteatoma, small area of hyperintensity. So small soft tissue process space, use your clinical information. They knew there was most likely a cholesteatoma. They can see through the membrane very well. But DWI restriction is pathognomonic of cholesteatoma in the right clinical context. Non-epi diffusion is to be done in coronal and look behind the middle ear, because the syndromic causes of hearing loss are a problem. This we published as a case report because it was the first description of anatomical abnormality in MASP1 gene mutation, so 3MC syndrome, explaining the known hearing loss. So the pars flaccida cholesteatoma is the most important. This is the pars flaccida that creates between the malleolus, the membrane, and the ligament here. The theory says that normally you have a drainage of debris and basically skin cells. But if you have decreased intracranial pressure, you have this accumulation in this location that form the cholesteatoma. Cholesteatoma is, as you know, a misnomer, and the radiological characteristic of cholesteatoma is restriction and erosion, and this is a typical erosion of a big cholesteatoma without enhancement. Remember, T2 hyperintensity, no enhancement, very important, and diffusion restriction. So this is, if you want to have a screenshot, erosion, T2 hyperintense, T1 hypointense, and no enhancement, plus TWI restriction. And you need to do the right TWI sequence, has to be spin echo or a multi-shot, but better a spin echo and in corona. Don't do the brain epiplanar, which is a gradient echo diffusion, because we'll have too many artifacts and will not be reliable. So it's very important to do your protocol right, and remember T1 hypointensity and non-enhancement that allow us to distinguish this from inflammation, cholesterol granuloma, and so on. This is another case. You can see bilateral cholesteatoma here on both sides with dark signal on ADC. This is a multi-shot that shows some artifact that should not be there in a non-epi, and you can see the appearances of this fluid in T1 that then was not just a bit of fluid, was actually cholesteatoma. So I told you about the importance of protocols in head and neck region, and we wrote this consensus paper, multi-center international consensus paper, with a lot of experts and endorsed by a lot of society, including European Society of Neuroradiology, ESPR, and European Society of Head and Neck Radiology. Please read it up. There is the temporal bone protocols, but not only, also the approach of complex orbit, skull base, neck, children pathologist, and so I invite you to read this. Pars flaccida cholesteatoma, what are the differential diagnoses? Pars tensa cholesteatoma radiologically is the same apart from the location. So posterior tympanic recess, you see it here, displacement of the ossicles and erosion anterolaterally, opposite of the pars flaccida cholesteatoma. Otoscopy wise, you can have some information from your ENT, but the CT is very important to localize the cholesteatoma. DWI will not be able to do so. Granulation tissue, no erosion, but intense enhancement, common. You can have erosion, actually. I will show you an example afterwards, but most of the time there is no erosion. Middle ear cholesterol granuloma is evident on the otoscopy, but the interesting thing is that apart from the blue eardrum, high signal in both T1 and T2 and hemorrhagic changes may show some CT erosions, but this is extremely rare. It's more difficult to distinguish the cholesterol granuloma from hyperintense proteinaceous tissue in the petrous apex, but keep in mind this differential is rare. But when you encounter something that is eroding both T1 and T1, T2 and T1 hyperintense with blue eardrum, your diagnosis is there. Other differential diagnosis is post-inflammatory ossicular erosion. So there is an ossicular erosion that is non-cholestatomatous. And look at this case. You have soft tissue, but normally looking at the normal side, and I show you some anatomy before, you should have these two parallel lines, anterior malleolus neck and tension tympanic tendon, and posteriorly incus lenticular process and incudiostapetal joint. The posterior line is gone in post-inflammatory ossicular erosion because this is quite weak, and you have so absence of posterior line and ossicular right angle, that is this one that you can see here, that is lost. In particularly, you have missing here the horizontal part because of the tissue. Now, of course, this is a very weak point, so you don't need a cholesteatoma to erode this area, but also chronic, particularly aggressive inflammatory process can do so. Keep in mind that as a radiologist, we do need always the clinical correlation because there is an overlap between these two. So don't be so dogmatic in the approach. And look at the tympanic membrane that should be actually clean, while in the cholesteatoma, the ENT will see, or the otologist will see some atypical abnormalities and not a clean tympanic membrane. So again, very important, your clinical correlation. Middle ear differential diagnosis, don't forget the uncommon, unexpected. Use your clinical context. Temporal bone is a very good location for LCH. This is an erosive process, but this is actually a tumor. And you look at the spine, there is vertebra plana. You look at the skull, typical outpouch erosive lesion. So the context is important, but remember LCH, yeah? And also, this is an amazing case from Dr. Taranat, and look at boy with beta thalassemia Meyer, and this was extramedullary hematopoiesis. It's very difficult to do this diagnosis on radiology alone. That's why it's so important to keep a dialogue with your clinician. Look at this other very interesting patient with KID syndrome. KID syndrome is hearing loss, but also eye problems, skin abnormalities, and is associated with this gene called GJB2. Not important, just to show that sometimes in pediatrics we have such rare cases that we really need to Google it to know all the associated findings, because we may want to look for them. Look at this case. Again, very small tympanic membrane. Inner ear looks normal, but look, there is soft tissue in the external ear. So now I told you that conductive hearing loss is all the way from the pinna to the oval window. In this specific case, we have external auditory canal opacification with the soft tissue, and also malformation of the posterior fossa that are probably related to the syndrome. But this is an ESC cholesteatoma? Well, actually, if you see, there is no erosion. Where is the erosion? This is keratosis obturans. So this is a lot of keratin occluding, blocking the external auditory canal, differently from the cholesteatoma that should erode the scan. So remember, the keratosis obturans is very rare in children, but it's possible. And also, looking at the literature, some people reported posterior fossa malformation in KID syndrome. So in this case, again, the bottom line is not, the teaching point is not, oh, you need to know this gene, but if you come across something syndromic and genetic, keep looking and Google it, or look at your books, ask your colleagues, because it's very important to do not miss associated findings. What are the differential diagnoses? So typical keratosis obturans is with enlargement and without erosion, and is benign soft tissue, different from cholesteatoma. Cholesteatoma is characterized by scalloping, erosion, bony fragments within the mass, and the middle ear is often spared, like the keratosis obturans, but use your DWI as well. And remember that this can be a post-operative complication, not only congenital, but also post-traumatic. And this is a case courtesy from Professor Lorenzo Pinelli. So when you see internal bony flex, DWI, and submucosal mass, you see here, start from the submucosa, also from these drawers from Arnsberg book, think of external cholesteatoma. Necrotizing external otitis, very rare in children, unless they are immunodepressed, and you have swollen external auditory canal with erosion, cellulitis. Best imaging are on MRI. Remember, again, do your protocol rights and think of the clinical context. Tumors. Tumors, they are, this is a squamous cell carcinoma, typical of old people, but don't forget, in children, you can have sarcoma, aggressive sarcomas, and this is 4-day-old with infantile sarcoma, older children can have rhabdomyosarcoma. So it's very, very important that you consider different tumors in these cases. But when you see something aggressive, a pseudonecrotic here, don't call it necrotitis externa, because there is the mass. This is a mass, okay? So I'm getting to the last slides. I didn't touch all the inflammatory processes in the petrous apex or in the inner ear, like labyrinthitis ossificans, because you will have a lecture on the inner ear. This lecture and the lecture on inflammation based on this paper that we wrote a few years ago are on my YouTube channel, but please read this beautiful paper by Kelly Robson. Again, thank you very much for the invitation. These are my conclusion. Remember that MRI and CT are complementary, but for conductive hearing loss, use CT first. Look for associated abnormality, syndromic association. Don't forget the clinical context. So again, please get in touch if you have any comment, and see you next time.